Alright. Welcome to NeuroClarity, where we bring the tangled thread of neurology into razor sharp focus, one clinical radio at a time. In today's episode, we are diving into chapter 3 of Ching and Cheng's comprehensive review of neurology. We've got 3 high-stake, high-yield cases lined up, each one a real-world test of how well you understand brain edema, mass effects, and neuroprotective critical care. Are you ready to level up? Let's crack open the first case. Question 1. A 57-year-old man presents with sudden onset of headache, nausea, vomiting, and change in mental status. A scan is obtained as is shown in figure 3.1. Let us take a look at our image. The patient had a normal CT scan obtained 3 months earlier as part of workup for headaches. Which of the following is true regarding the brain edema occurring in the setting of the condition shown in the scan? A. It is associated with interstitial edema. B. It occurs from sodium-potassium ATPase pump failure. C. It is cytotoxic edema. D. It is vasogenic edema. And E. The pathogenesis is associated with blood-brain barrier disruption. What do you think? Well, this isn't your slow-burn chronic hydrocephalus. This is acute obstructive hydrocephalus, which is a plumbing emergency in the brain. Something, maybe a mass, blood, or even congenital narrowing, has caused blocked CSF flow and the pressure is rising fast. Let's talk about edema. When CSF can't drain, it pushes through the ependymal lining of the ventricles into the brain parenchyma, and this creates something we call interstitial edema, also known as transependymal flow. You will see it on CT as periventricular hypodensity, and it means the brain is swelling from inside out. Interstitial edema is extracellular, but it is not due to blood-brain barrier damage, that is, it is not vasogenic. Neither is it cellular energy failure, which we term cytotoxic. This is a hydrostatic pressure problem, and I want you to think of it as the ventricles overflowing like a backed up sink. Why is it not cytotoxic edema? Well, this is seen in ischemic stroke, usually due to sodium-potassium pump failure. Why not vasogenic edema? Well, that is seen in blood-brain barrier breakdown, and pretty much you see this in tumors. Why is it not a blood-brain barrier disruption? Again, that is vasogenic, and that is not the case. So, if you're following closely, I'm guessing you're saying that the answer is A. It is associated with interstitial edema. Next question. Question 2. A 62-year-old patient is found to have a brain mass. An image of his MRI is shown in figure 3.2. Let us take a look at it. Which of the following is true regarding the cerebral edema in this condition? A. It is caused by disruption of the CSF flow. B. It occurs from sodium-potassium ATPase pump failure. C. It is cytotoxic edema. D. It is vasogenic edema. And E. It is caused by obstructive hydrocephalus. What do you think? Now, let us take a look at that image again. Do you see that ring? That ring is ominous, and the dark halo around it, that's edema. But the question is, what type of edema is this? This is the classic vasogenic edema, a telltale sign of blood-brain barrier breakdown. Let us talk about the mechanism. Normally, the brain's endothelial tight junctions are fortknots. But when a tumor grows or an abscess brews, it releases cytokines, vascular endothelial growth factors, and other agents that pry those junctions open. What follows is a leak of plasma proteins and water into the extracellular space. The result is edema that is extracellular, asymmetric, and prone to shift brain structures. It respects white matter tract and spares the gray matter, helping you to differentiate it from cytotoxic edema. Other choices, which includes CSF flow disruption, is wrong. Why? Because CSF flow disruption, like we said earlier, leads to interstitial edema, which causes your classic hydrocephalus. Sodium potassium ATPase failure is also wrong because, like we said, this is seen in ischemic stroke causing cytotoxic edema. And obstructive hydrocephalus? Nah, like we said earlier, that is not in this case. That will cause interstitial edema. So, our correct answer is D. It is vasogenic. Next question. Question 3. A 52-year-old man suffered a cardiac arrest associated with ventricular fibrillation and required cardiopulmonary resuscitation, that is CPR, for 10 minutes. On arrival at the hospital, the patient is unconscious. He is intubated and admitted to the ICU. Which of the following is correct? A. Therapeutic hypothermia is not recommended after ventricular fibrillation. B. The target temperature with hypothermic therapy in this setting should be 30 degrees to 32 degrees Celsius. C. Evidence demonstrates the benefit of a temperature goal of 32 degrees to 34 degrees Celsius for 12 to 24 hours. D. Therapeutic hypothermia is safe and not associated with any complications. And E. Neurological outcome in this patient will not improve with therapeutic hypothermia. What do you think? So, let us summarize this question. You have a 52-year-old male who suffered a cardiac arrest from ventricular fibrillation. You did a CPR, which was successful after 10 minutes, but now your patient is comatose and is in the ICU. You've saved the heart. Now, it's time to save the brain. Let's enter the world of therapeutic hypothermia, which is more formally known as targeted temperature management, TTM. Post-arrest, the brain is a storm of inflammation, excitotoxicity, and apoptosis. Cooling slows down metabolism and preserves the blood-brain barrier. It reduces free radicals and it protects mitochondria. In short, it buys time and function for the brain. In the Gen Z's world, take a chill pill. There is something we call the Goldilocks zone. You aim for 32 degrees Celsius to 34 degrees Celsius and you maintain it for 12 to 24 hours. If you cool below 32 degrees Celsius, that's too cold and you risk arrhythmias, coagulopathy, electrolyte derangement, and infections. What does the evidence say? Evidence shows that this therapy is most clearly beneficial in ventricular fibrillation arrests, but it has also been applied more broadly to pulseless electrical activities and asystole, even though the data is less robust. Recent trials suggest that even controlling temperature up to 36 degrees Celsius can be effective, so think of active temperature management, not just passive waiting. So, from our options, our correct answer is C. Evidence demonstrates the benefits of temperature goal of 32 to 34 degrees Celsius for 12 to 24 hours. And that's a wrap for this high-yield episode of NeuroClarity. If today's cases brought your neurology game up to a notch, like, share, and follow us for more brain-boosting breakdown. Until next time, keep your neurons sharp and your thinking clearer than ever. Bye for now.